time to speak to our group today. I'm going to turn it over to you.
Good afternoon. I'm going to share my screen here and see if I can pick the correct one, and let's hope that that goes well. What I wanted to tell folks about is some of the research that we're doing here at the University of Arizona. And on the title slide, you see my name and also my partner in crime, Dr. Torsten Falk, who does a lot of the basic lab research here, is in charge of that part of our program. And I know he'd love to come talk to your group sometime too. And he's lent me some slides from our research lab that I'd like to go into. Some of them are technical, but we'll kind of get through those and leave some time for questions. So I thought I'd start with just a little bit of background about Parkinson's. And let me see if I can advance the slides. I think that, you know, a lot of people will know sort of the basics of this, but just so that we're all on the same page, I'm going to go through this rather quickly and then get into some of the basic science that try to explain that and bring it back to earth and kind of point out just some studies that are open that people with Parkinson's are able to participate in, depending on what particular problems that you may have that would respond to our treatments. So, of course, Parkinson's disease is a very common neurodegenerative disorder. It's the second most common neurodegenerative disorder. We all know there's lots of people with Parkinson's, and most of them don't come to support groups for some reason, because we know probably 20 or 30,000 people in Arizona alone with Parkinson's. So getting them all organized would be a wonderful job, a wonderful thing to have. And I'm happy to support any group that's working toward that end. Well, what causes Parkinson's, we don't know. Some complicated interaction between genes and the environment. What I want to focus a little bit on this talk is, here's a picture of the brain, and it's the midbrain, this area here, that's mostly affected by Parkinson's. And then if we were to look under an electron microscope, we would see something called a synapse that I think everyone's heard of, sort of in the common parlance, but this might be what a synapse actually looks like. You know, a very small structure that you need an electron microscope to see, but a lot of action of dopamine release and a lot of the research has to do with these synaptic endings. And I'll show you some real pictures of synaptic endings that we've got from our lab. They're quite as pretty as this cartoon picture. So the scope of the problem, of course, for us is really tremendous. Over 1 million Americans have PD, 10 million people worldwide. 1% of people over age 55, probably 5 to 8% of people over 65 have Parkinson's. I mean, this is a common problem. And I will sort of make my plea. I think, you know, our research is funded, but I think we could use a lot more research across the board. So if you ever have a chance to advocate for more funding for Parkinson's disease, I'm sure there's lots of deserving research that is not fully funded. And I think that the scope of the problem could match a little more financial commitment to Parkinson's at a state and federal level. In the meantime, of course, donations from people are helpful too. If we were to look at the brain of someone with Parkinson's at a few different levels, this is a slice, an actual slice of brain. Someone donated their brain after they were done with it to the anatomy lab. And we can see that there, one part of the brain called the midbrain, that's sort of right in the center. There is a black stripe of cells that is called the substantia nigra, which is Latin for black stuff, because in medicine used to have to make it sound fancy and couldn't speak English. So substantia nigra is sort of the fancy word for this black stuff. And people with Parkinson's, there is damage to the cells that make up this black stuff. If we were to look under a microscope, we could see this black stuff consists of all of these individual cells that are darkly pigmented with neuromelanin that makes them dark. And with Parkinson's disease, you can see that there's a loss of these darkly pigmented cells. When the loss gets to be about 60 or 70%, that's when symptoms of Parkinson's can occur. If we look at an even higher level, we see maybe one of the basic culprits of Parkinson's, this pink sphere with an even darker pink center is called a Lewy body, named after the pathologist, Dr. Lewy, that discovered it. And the Lewy body is made of a damaged protein, alpha-synuclein. Whether this itself is the bad guy or whether that might be the attempt of the brain to sequester damaged proteins in a way of trying to heal from Parkinson's is still not clear. But it is a marker that the pathologists use in order to confirm that someone has had Parkinson's. We don't have a way of looking at that in life. Only on an autopsy can we see that. But we do have a way of diagnosing Parkinson's during life. This is something called, these are a nuclear medicine scan. This is called a DAT scan, kind of like a CAT scan, except the D is for dopamine. Mostly used for diagnosis of Parkinson's, but we're beginning to start to use this technology to monitor quantitatively the progression of Parkinson's. And so while we can't see the cells of the Lewy bodies, in this image, we see sort of a whole slice of a whole brain. So the eyes would be here, the back of the head is here. This is just a typical scan. Someone's lying down on a stretcher and there's a detector over their head. They've been injected with a radioactive tracer that'll last for a few hours. And then this image appears. And we can see that where the dopamine cells are in a young person that doesn't have Parkinson's, there's like a giant red stripe that contains all of these. Even in early Parkinson's, this starts to break up because there's damage to these dopamine cells. And as Parkinson's advances, this can get even worse. There is a background change too. I won't talk about that so much, but we'll look at this. And so people generally that might know they have Parkinson's by the time they're in a support group or knowing this, but this is mostly for early diagnosis, but it's going to be coming online as a way to see if various treatments may work to help to restore or slow the progression of Parkinson's. Talking about the progression of Parkinson's, there's been some various schemes about how that happens. And I'd like to go over one of them that's by the husband and wife pathologist team, Brock and Brock. And here's a picture of the human brain in a cartoon sense. So the eyes would be here. This is the back of the head, and here's the brainstem and the base of the brain. We think that Parkinson's may actually start not so much in the middle of the brain, but it may actually start outside of the brain in cells in the gut or in the vagus nerve. The constipation and low blood pressure are very early symptoms of Parkinson's, and they can occur in retrospect years before. So we think that it may sort of start and kind of spread up through the brain. And that can kind of explain some of the symptoms. So early on, there's autonomic symptoms, symptoms of the autonomic nervous system that include low blood pressure, difficult changes in sweating, constipation. That set of symptoms can occur very early on, but they can stay. Later, as it gets into this area of the brain that controls sleep, we know that sleep is a big problem in people with Parkinson's, and that would be a lecture in of itself, but there's lots of different ways that sleep can be impaired: REM sleep behavior disorder, poor sleep. Also, this part of the brain is where serotonin is made, and so depression can occur even before any of the symptoms. Then typically, as the Parkinson's reaches this midbrain area where those pigmented cells are, that's when we see the movement symptoms. That can actually be later in the course of Parkinson's, and only in retrospect do we know these. And finally, in some folks, if the process can include part of the cortex, there could be problems with memory and concentration. Those can be mild, but they can be severe in some individuals. So that's the anatomic view. And then sort of from the stage, there's another way of staging Parkinson's that, the reason I cover this is people often ask me, what stage is it in? It's not an easy question to answer. One staging scheme has been this so-called Hone and Yar, named after two neurologists. So stage 1 is when symptoms occur just on one side of the body. And in Parkinson's, they often do just start on one side. Right versus left is random. Can be either way. It doesn't have anything to do with handedness. Stage 2 is when the symptoms begin on the other side of the body. That can occur variable times, often 3 to 4 years after the onset. In reality, it may be that the side that starts, even then there's some subtle findings, if the right hand has symptoms, some subtle findings even in the left hand if you look hard, but eventually both sides are affected. In stage 3, it's defined by loss of balance or balance problems. In the clinic, we test that by pulling people back, and we have a particular test. Stage 4 is when somebody needs help with their activities, and balance problems are worse. Stage 5 is when people are in a wheelchair or bed-bound condition. And I point out, this is depressing, but a lot of people never reach that stage with their Parkinson's. So this is the staging, one system of staging. Matching that, I don't want to talk a lot about treatment, but just to sort of say, there is sort of a continuum of treatment that kind of matches those stages. And exercise is always the earliest treatment, and that should continue throughout. But we have a range of drugs as the symptoms worsen. We might go through drugs in this order. More recently, we found that it's okay to use levodopa as the first agent. There's been some debate about that, but starting levodopa right away is legitimate. As symptoms progress, we may go on to more invasive therapies such as deep brain stimulation. So this slide just sort of shows, the motor symptoms of Parkinson's. To remind you, those are defined by slowness, stiffness, tremor, and balance problems. But there's also a lot of non-motor symptoms, and those can cause, just as many problems, and they need separate treatments. And we talked about some of these in our scheme, decreased sense of smell, but as this moves up the brainstem, depression, pain can be involved. I've heard people say that Parkinson's is not painful, and generally that's not true. There can be lots of different types of neuropathic pain that can occur within Parkinson's. Sleep, fatigue, autonomic symptoms that can cause bladder and bowel dysfunction. So these are the non-motor symptoms. I wanted to highlight that just for 1 second to talk about one treatment. So one thing that can happen in these non-motor symptoms is people with Parkinson's can get low blood pressure. And this can cause dizziness or lightheadedness when standing. Sometimes the low blood pressure can cause a fatigue or headache, particularly symptoms that are worsened by standing. And there are various medication treatments. There's a range of treatments, but there's a few medications, midodrine and fludrocortisone. There is sort of the newest treatment for this dizziness, which has the formal name neurogenic orthostatic hypotension, meaning it's caused by a neurological problem, not a heart problem or a blood vessel problem. Orthostatic means you're standing. That's just fancy Latin word for that, and hypotension, low blood pressure. So there's a medication called droxidopa. That sort of sounds like levodopa, and it is related. It helps replace not dopamine, but a different brain chemical that becomes low norepinephrine. It is available by prescription. So this study, we have a study called the RESTORE trial. It is a study of looking at droxidopa for a longer period than earlier studies. So I want to be clear, like your physician can go ahead and prescribe this. It's available, by prescription, but the research study is an opportunity to flesh out the longer term safety of the drug. And I will point out, like, this study has what's called an open label titration, meaning if someone comes into the study, they're going to get the real drug at a known quantity, and we will work with them, or research staff, myself, will work with the subject to raise the dose until we have it just right. And then after the dose is just right, and we think we've controlled the symptoms, the double-blind part, the real test, is that later in the study, some patients will get a placebo tested, mixed in instead. And then we'll see if there's really a change. So it's a little bit different than other studies that are double-blind, where you might get a placebo right from the beginning. This one, everybody gets titrated on the drug. And of course, if you did get the placebo and it was making a difference and you needed it, we could stop the study and then you could go on the open label drug. So it's kind of a no risk way to see if this is a good match for you. So I'll have some contact numbers, and if you have low blood pressure, this might be something you're interested in. We may only have this study open until the end of the year. We're looking for an extension, but as long as we make the initial contact before the end of the year, we could do the longer part of the study next year. So a little bit of urgency to contact me if you think you might like to get involved in this. Okay, let's move on. What are some potential goals of treatment of Parkinson's in general? Well, there can be symptomatic improvement of movement. That's one goal, of course. I mean, that should always be the goal in using medications. Another goal that would be a topic of a whole nother talk would be control of non-movement symptoms, the fatigue, low blood pressure, problems in concentration, problem in memory. All those things that are not movements can be just as significant in quality of life in people with Parkinson's. And so, more studies in that, or having your doctor control those, can be important too. And then we sort of get to what I think is like the holy grail of Parkinson's research, which we're not really right there, but this has been called neuroprotection, or maybe a better way to say is disease modification. In other words, is there some treatment that we can use that alters the course of Parkinson's? Obviously, we want to alter it for the better. In other words, it would slow progression of Parkinson's, or perhaps it would salvage some of those dopamine cells. At the very least, it would prevent those changes that we saw in the DAT scan from progressing as quickly as they might otherwise. Some researchers feel like in order to really do this, we would need to have very early diagnosis, and that may be true. But I believe that this sort of concept of disease modification, that we should be able to apply it at any stage in Parkinson's. Otherwise, we're sort of relegated to trying to find people that are newly diagnosed and only do studies on that. And that's not, in my mind, a very good way of really disseminating the research opportunities. But in terms of outside of a research study, keep in mind, right now, exercise is the only proven therapy that can modify Parkinson's disease and slow progression. So we're looking for gene therapy and drug therapy and all of that, but we don't have anything that we can really say works yet. Everything else is still research, but we know that exercise really can help protect the brain. And so exercise is always important, but if you have Parkinson's, it's sort of doubly important. Well, let's look at what happens with advancing Parkinson's. here's a slide that shows what happens in particular in treatment with levodopa. Early in Parkinson's is sort of the honeymoon period. Shown here, people can take their levodopa once or twice a day or 3 times a day. It works really well to control the symptoms. That's great. In moderate Parkinson's disease, it's necessary to take the levodopa or other medications more frequently. And we see because the brain cannot store the levodopa as well because there's less cells, people become more dependent on taking the medication more frequently. And there becomes this up and down in the blood level of levodopa. And there may be times when it's too low, we call that an off period, or times when it gets too high where involuntary movements called dyskinesia can occur. And in some people, this fluctuation can just become very chaotic. And so moving between the off and on periods and trying to get the medication just right can really become a chore. And sometimes it seems like there's no amount or timing of medication that can really work. I'll just show this in a little different slide. One thing that we kind of can look at is the therapeutic window, which is this area between here and here. So early in Parkinson's, you take levodopa, the blood level goes up and down, but it's all within this wide therapeutic window, which is normal. So you don't notice these blood levels going up and down. As the Parkinson's progresses, this therapeutic window becomes more narrow. In between doses, PD symptoms can reoccur. We call that wearing off. I'm sure many people are familiar with it, and there's lots of tricks to treat it. And then what can happen is after 5 or 10 years or later in the course, this window, the normal window, becomes very narrow, and people spend a lot of time outside of the therapeutic window, either with off symptoms or with on symptoms of too much levodopa effect that's called dyskinesia. And this is one area that we're focusing on right now as a treatment for this dyskinesia. Well, one treatment for motor fluctuations already is DBS, and this uses a high frequency electrical stimulation. That can be the topic of another talk, but I want to mention it because it sort of has to do with the topic I'm going to talk about. As you know, DBS, it consists of a pacemaker-like element, just like people have a pacemaker for the heart. There's a wire and then there's an electrode that goes into the brain that's placed by a neurosurgeon. And these wires can help control the symptoms of Parkinson's independent of medication. We'll come back to that. So let's launch into some of the things that we're doing in our lab. One of the goals of our laboratory research is we want to understand this levodopa-induced dyskinesia at the molecular level, what's happening really from protein interactions, at the cellular level, how cells talk to each other, and systems, by that meaning how different brain areas can talk about that. We want to understand this because we are involved in development of therapies that would provide future treatments for Parkinson's, particularly interested in disease modification. And my particular role is translating this research to clinical trials. So when we have something that we've discovered in the lab, eventually we want to make that available to people with Parkinson's. And that process, unfortunately, can take many, many years, as I'm sure you're aware of, but hopefully we have some tricks to speeding up that process, because we can't wait so long for these laboratory discoveries to make it to where it's improving the quality of life of people. Well, I want to talk about brain oscillations and Parkinson's disease as the topic. By brain oscillations, I don't really mean that the brain is physically shifting so much, but really, if you could think of the brain as a radio that transmits information from one area to the other, and you can imagine the brain has lots of information that has to get from one place to another. information that you're seeing through your eyes and information that you're hearing through your ears. Somehow all of that has to come together in some area of the brain where you can see the whole picture and understand that. So obviously, those brain areas that are involved in that have to talk with each other. And we think that they communicate using different channels of communication. And this balance of frequencies is altered in Parkinson's. So some of the terms that we have for some of these frequencies, you could think of them like a radio dial, is the lowest down on your dial, the slowest is called alpha frequency. We think that that has to do with tremor because it's about 4 times per second, which is the same as the frequency of Parkinson's tremor. This beta band frequency, which is about 40 to 60 hertz, is highly increased in Parkinson's. And we think that this beta is sort of a bad actor when it gets out of control. And a lot of therapies are aimed at reducing the quality and type of this beta band of information. And then gamma is another high frequency that we're not quite sure what its role is, but probably has to do with little groups of cells speaking with each other. So I want to point out that how deep brain stimulation works is it actually injects a frequency in the brain. Your doctor can control that frequency. It's usually about 60 to 180 hertz. The typical DBS uses a frequency of 130 hertz. Somehow this acts like a white noise to kind of quiet down frequencies that are pathological. So in particular, in Parkinson's disease, this beta frequency is harmful. And in some way that we don't completely understand, DBS uses a different frequency to counteract that. The companies involved in DBS are beginning, more research is coming, and eventually, for patients that have DBS, these devices are going to monitor the spectrum of frequencies that are occurring in the brain in real time. The physician is going to be able to have a look and see what those frequencies are, and will be able to customize the device to control these frequencies. So this area of brain oscillations and how it plays out in helping people with Parkinson's is really right around the corner. Our understanding is not complete, but we'll make use of it anyway. That's pretty typically how medicine is. Something works and we don't know why, we go back and discover how it works, and hopefully then we can build it better. And I'll just start to show some pictures from some of the work from in our lab. And I can't go into too much detail. I mean, this is sort of for a scientific audience, but they kind of have some pretty pictures, and I think that we can make the point about this. All of this business here, this is what's known of the internal circuitry that is involved in Parkinson's. So these 6 or 7 elements, different parts of the brain, we know beginning to learn how they're tied together. And in each of these elements, these abnormal frequencies have a role to play. If we were to stick an electrode into a human or one of our experimental animals, at any point we can measure the spread of frequencies. That kind of comes out as like a color map like this, where the brighter the color, the stronger the frequency is. And this is kind of the frequency. And you can kind of see by this type of a map, with Parkinson's, there's this sort of abnormal spread of activity by this red area. I mean, I'm just looking at it, almost looks like a Doppler radio storm, like something that you see on the Weather Channel. It just occurred to me. But like maybe this would be, you could think of this as a storm of bad activity. And with the deep brain stimulation, you can see that it becomes limited. So we know that in research, but we're beginning to be able to see that in real time. And of course, the deep brain stimulation can be placed in a number of these different targets that are elements. So the subthalamic nucleus is the most common place, but the GPI, thalamus, those are all words that many people with Parkinson's have become sort of household terms because they may have had a deep brain stimulator implanted. The typical deep brain stimulator operates at 150 hertz, and this is where I wanted to get into our work with ketamine, because ketamine induces a frequency when we give it intravenously of 130 hertz. And so we think that this therapy is sort of like, we've been calling it a chemical DBS. So let me delve into this ketamine story just a little bit. You know, ketamine was discovered as an anesthetic drug. It's a very safe anesthetic drug. It has some properties that make it ideal for use in the field instead of in the hospital. So during wartime and disasters, like ketamine can be used when other anesthetics can't. It has been used in sub-anesthetic doses more recently. There's been a lot of press available for it because when we give it in a dose that doesn't put people out, you know, they're still awake, may feel a little groggy, it can be used to control pain. It is an FDA approval now for treating depression. And what our research is showing is that it has benefit in Parkinson's and it can control levodopa-induced dyskinesia. It does all of this by altering brain oscillations. And so that's something that we're very interested in, is how ketamine works. Perhaps we can make it work better, or even coming up with new symptoms. So just to show you some slides from our laboratory, this is a section of a rat brain. It's not a human brain, but this brown area here is where the dopamine cells live, and that's been stained with brown so we can see it. On this side of the brain, you can see that there's not dopamine neurons. That's because we have induced Parkinson's on one side of the body, hemi-Parkinson's, in this rat brain. By using certain toxins, we can kill off all the dopamine cells. And because rats don't live long enough to get Parkinson's on their own, you know, 2 or 3 years, but we can induce Parkinson's. Then we can put in some microelectrodes into this brain area where we can study the electrical activity. And all of that looks like this little electronic chip that's just less than an inch long, but you can see it has these little probes that go into the rat brain. So Dr. Falk and his team is involved in the business end of carrying out these experiments. And then we've used this setup to test ketamine. And now, without getting into too much detail, just see if I can go through these. I want to show you what happens. We'll just focus on this panel here, and let me explain the experiment. So these are electrical recordings, the sort of weather map from animals that we've given Parkinson's to. Not only have we given them Parkinson's, but we've kept them around for a long time, and we have given them repeated doses of levodopa to the point that they've developed what humans get, levodopa-induced dyskinesia. So they have abnormal movements, not dissimilar from people, where they can make some twisting or turning movements that aren't normal, that happen just at the height of the levodopa dose. So we sort of created this animal model of it. And when we study their brains, when we give the levodopa, when this dyskinesia occurs, if we look in this channel, we can see all of this bad brain activity that's occurring right around at 60 hertz that's showing up really with this red area. And of course, we measure from different brain areas, but we'll just use this one from the motor cortex, the sort of thinking part of the brain, as an example. You can see just after a dose kicks in, really a lot of activity. If we use a low dose that doesn't cause dyskinesia, then that activity doesn't occur. So we have a pretty good model of what happens when the levodopa goes over that threshold. Now, we're going to treat the animals with ketamine and do the same experiment. We give them levodopa and we see what happens. And we can see that this bad activity is almost completely suppressed. And we're seeing that in clinic too, that patients that have levodopa-induced dyskinesia, if we give them ketamine, it completely suppresses the dyskinesia. In fact, it actually improves the tremor and all of the symptoms of Parkinson's. And that's interesting in and of itself. But let me tell you, the really important and exciting thing about this is that not only does it happen during the ketamine treatment, but even after the ketamine has long gone from the body, the benefit remains. So the bottom line is we think that a ketamine treatment given once or twice a month, or given once or twice, may have at least a 3-month effect or longer. So we're developing ketamine not as a medication that you'd have to take all the time, but really as a treatment that would occur maybe just one time or at certain intervals. And that even after the drug had left the body, it would alter these brain functions in a beneficial way. And so that's what we're seeing in the lab as well, that there's long-term benefit in sort of restoring these signals to normal. Let me jump past the science a little bit here, and I just want to show you one picture of like, how is it that we think that ketamine might be producing these really long-term benefits? And you know, it's hard for us to see into the human brain to know what's happening, but using our animal model, we can get a pretty good vision of something that might be happening. So at the very first slide, I showed you that picture of a synapse. And that was just a drawing. But these are electron microscopic views of actual synapses in a rat brain. And I want to point out something that happens here. In an animal with Parkinson's, they actually develop these abnormal synapses that are called mushroom spines, because in somebody's mind, they look like a little mushroom sprouting. But you can see that there's, in this little view, there's 1, 2, 3, 4, there's 5 of these abnormal mushroom spines. And we know that those correlate with dyskinesia. So what happens in Parkinson's when people are repeatedly exposed to levodopa in the setting of Parkinson's, or maybe just from the disease process, is they develop these abnormal brain structures. And those are pretty much somewhat permanent. It's not, doesn't come and go with each dose. They're there weeks and months or years at a time. Our one-time treatment with ketamine has reduced the number of these just to 2 in this example. And of course, this is just one example, but we've done studies where we've, you know, either had graduate students or gone through the computer program and counted these in many, many different instances. And this is holding up in a quantitative manner. And, you know, that data is over here for scientists that are skeptical and they can look at all the numbers. But looking at the graphics, we can see that. And just to be sure that this is real, if we give ketamine, but we give a blocker of a brain chemical BDNF, we can see that we can block the ketamine effect. And that gets at one of our lab's goals in all of this is to sort out exactly how ketamine works. Maybe we can come up with something even better or understand better how to apply it. And Dr. Falk we published this scheme, and it's complicated, but you know, this even simplifies it. But K is ketamine, and we've sorted out how it works. And this is a complicated scheme, but the thing that's so exciting about this is I want to talk about this guy here, BDNF, which is called brain-derived neurotrophic factors. Because for many years, our lab and other labs, we have been looking for something that could protect the brain and help the brain restore its physical structure back to normal. And there's been many trials with some of these neurotrophic factors, things like GDNF and BDNF and a whole alphabet soup of them. It's really been hard for us to try to get these as treatments for patients because it would require gene therapy, injecting genes into the brain, or injecting cells into the brain. And I think all of that is coming, but you can imagine that is a giant step to take. But by using ketamine, we're seeing that we can increase BDNF in the brain using a treatment that is not genes or not cells. It's an FDA-approved drug, you know, that just can be given as a small molecule like any other drug, and its safety is well defined. So we have a roundabout way of kind of getting into increasing these growth factors. And this is like really exciting for us because it might give us the key into changing the brain structure. So we are, as we speak, we're kind of undertaking studies in which we're doing analysis of rodent brains, looking at the cell types. We're finding some really interesting things that ketamine, some of the long-term benefits may include like reduced brain inflammation. We just published a result on this. Here in this panel, we see in green are some cells that are involved in inflammation in the brain. And those can be really reduced by ketamine treatment. So we are hoping to move this therapy into the realm of really getting at the disease modification. I just want to point out we're studying like how long ketamine lasts. Here's some examples from our rodent studies where we're looking at after an injection of ketamine, how long it lasts in the system and what metabolites occur and if these metabolites are important. This is called pharmacokinetics. We look in the brain in animals, but we're studying these in humans. That's something we can do as well, and we're going to match up these results. So let me get to the real study part in the last few minutes here. Our theory is that 2 5-hour infusions of ketamine given 1 week apart will give lasting suppression of levodopa-induced dyskinesia. We have a phase 1 open label study. It takes 4 visits. 2 of them, patients receive the drug. Getting the drug is an all-day affair. It happens in our infusion suite. And unfortunately, I wish we could say it would be just like a one shot, but what all of this research is showing is that in order to reset the brain and to have an effect on those brain structures, the minimum amount of exposure to ketamine needs to be 10 hours. And it's not practical to have somebody in one place, you know, for 10 hours. It gets to be a long day. So we've broken this up into 2 5-hour treatments, which is manageable. And we've done more research to show that in the rodent model that works as well. So we're kind of hoping we're down to the minimum amount. Studies from our initial study show that this works, that at least by 3 weeks after infusion, there's still long-term benefit. So this is long after the drug has left the body. So we do have this trial open, and if anybody knows anybody or is interested, they can contact me. This is the inclusion criteria, is that people have Parkinson's disease that does respond to levodopa, so being typical Parkinson's, and that they have at least 2 hours per day of dyskinesia or bad on time where there's involuntary movements. The couple things is that if you have high blood pressure, ketamine raises blood pressure, so that might be something we'd have to monitor. And I want to let you know, like people with DBS, unlike most drug studies that are put out by drug companies, people with DBS are allowed in this study because we're interested in understanding the connection of DBS and ketamine, and we think the two may work synergistically or work together. So if people have DBS and they still have dyskinesia, sometimes that happens, or still have effects, they are allowed into the study. We're going to be recruiting until fall of next year. We have funding to do this. And we're asking for permission to include up to 20 subjects. So we'll have room in the study for folks that are interested locally. This is what would happen during the study. On the first day, we start out with a real low dose, and every half an hour, we turn up the infusion with a goal of 0.3. I know that doesn't mean much to you. This level, 0.3, is the level where people start feeling a little bit groggy and might feel a little bit strange, somewhat like an out-of-body experience. If that's at all comfortable, we can back it down to a level where there's no side effects. Once we know what someone's level is, they come in the second one, and whatever level that was, we just start out with that. So for this person, made it up to 0.3. The second infusion is just going to be 5 hours at the 0.3 dose. There's 2 hours of recovery period, so that people aren't loopy when they go home, and that it's safe for them to go home. So it is an 8-hour protocol with a 2-hour observation period. And if some people are volunteering, that we can get blood samples every 30 minutes at the end through an IV that's just there, so we don't have to keep poking people. And that gives us that so-called pharmacokinetic study that's important to us. There is a phase 2 trial that is starting as well. We'll be one of the sites, this is being conducted by PharmaTher, a pharmaceutical company that's licensed as ketamine. But the phase 2 trial, it is blinded, and so some people will get placebo. And, you know, that's the only way that we really know that something works, is if we compare it with a placebo. Because the problem with the phase 1 trial is, I know the patients have gotten the medication, and the subjects know, everybody knows. And so there's definitely a real placebo effect. And you know, that could cloud the results. So at some point, we really have to find out if the drug is working. And so we have to blind it so that the physicians and the people getting it will not know what they've had. Since the drug causes some drowsiness, we really need to blind it so people, you know, wouldn't be able to say, well, I know I got ketamine because I kind of felt something. So, so the people that aren't getting it are getting a mild sedative called midazolam. So everybody's going to feel a little bit sedated, and hopefully they won't be able to tell the difference which is which. And that'll be a more proper control. So, you know, this phase 2 trial is what the FDA is requiring for approval of this therapy. There's really no way around it. My problem with it is that it means that somebody's volunteered and they've never really gotten necessarily an effective treatment. I think just for fairness, one thing that I will be locally, what I like to do with my studies is, if people are in that double blind part, is offer them what's called an open label extension. So after people have volunteered and they've been in the study, but who knows what they got, after that, they will be eligible to get the real treatment in a way that the doctor and the physicians knows that they've gotten it. And that seems like a fair way to do that. So we're going to be working to always try to make these open label extensions that doesn't, you know, the scientific validity is going to come from the blinded part of it. But this way we get more information about safety, and we can be sure that people get the therapy. So that is where we're at with this. I'm going to just leave this information up. I don't know, I was hoping it would be in person. I would hand out sheets, there's a couple important numbers. There's my email, which you can always find, just is on the departmental website. Here's a number, 626-3576 to reach Scott Richards, who's our study coordinator. If you know anybody that's interested, or if you're interested, please feel free to reach out to us. I'm going to end there so that we do have a few minutes of time for questions. And I will, I guess I should maybe stop sharing the screen, or I'm not sure how we'll do that, but I'll just listen if there's questions.
So Dr. Sherman, we have a few questions in the chat room.
Okay.
The first one, and they all pertain to the ketamine study. The first one is, are there any negatives to using ketamine?
You know, we are still, the drug is approved by the FDA, but it hasn't been tested in people with Parkinson's. And so I haven't, so far with their subjects, there haven't been any long-term effects, but it can have some short-term side effects that are very real. People do feel kind of, I want to say it makes them sedated, but that's not exactly the right term. People can experience a little bit of a strange out-of-body experience from the drug. It is a dissociative anesthetic, and people sort of describe it to me like they either feel like they're floating above their body, or they feel like they're in another place, or that somehow they're disconnected. So far, I mean, that goes away when we turn it off, and so far everybody's tolerated that. But we are concerned it could be a disconcerting experience. And so that's why we feel like we have to be right there and sort of monitor, if anything, if people are finding that unpleasant or frightening in any way, that we can reverse that. We have drugs on hand to treat that. The other side effect is it does raise blood pressure. And at first I thought this wasn't going to be a problem because people with Parkinson's usually have low blood pressure. But we have found that during the infusion, the blood pressure might go up, and we have drugs on hand to treat it. But, you know, once we get to the point of getting it out to, you know, what we hope is eventually like a skin patch or something that people could use at home. And there, I think we're going to have to monitor that people are having a safe experience, that if they're feeling odd, but, you know, they're not in a monitored situation. I think that's sort of my concern, is how we get this out to the more general public of people with Parkinson's in a safe way. And I think we still, you know, the way forward's not completely clear. You know, a skin patch might be okay, but would it really be safe for people to take it alone at home? It might still need to be in like in their doctor's office for the first treatment, something like that.
Okay, thank you for that answer. The next question is, does ketamine address the freezes? So freezing in Parkinson's, would it, do you think it would be useful for that, or is it primarily for the dyskinesia and tremors?
Yeah, so that's a really interesting question. We had to pick something that we were going to focus on. And so we focused on dyskinesia as sort of the primary endpoint. But we are looking at many other aspects of Parkinson's disease. And so every patient, we're going to go through the Parkinson's disease rating scale, and there are certainly like questions and observations about freezing that's in there. I don't have any data yet about that. That would be great. I guess it's possible. I will say, unfortunately, like freezing is such a big problem for Parkinson's. We don't have a really effective therapy for it. So I thank you for that question. I don't know the answer, but I can tell you we will be looking very closely to see if it has any impact on some of these non-movement. I mean, freezing is considered a non-movement symptom in a way.
Okay, thank you. And then this question is the study available only to newly diagnosed? This person is saying they're already 10 years in their Parkinson's diagnosis.
No, it's available to anyone that meets the inclusion criteria, and that is that they're having at least 2 hours a day of trouble with levodopa. So, I mean, certainly not newly diagnosed. In fact, most newly diagnosed people might not qualify for this study. So, yeah, it doesn't matter how long you've had Parkinson's or what stage. You know, the one there, we do have an exclusion criteria, is pretty liberal. If people start having cognitive problems, we're a little bit concerned about giving this medication. So we do have a cutoff if people have Parkinson's dementia, but it's a very liberal cutoff. It's an MMSE score of 20. I don't know if that means anything, but might to your doctor. So we're accepting even people with cognitive problems, but we do have a cutoff just for safety. If people are confused, we wouldn't you know, we're concerned that the side effects might cause some disorientation, and we don't want that. But it's really pretty much open to most people with levodopa-induced dyskinesia that have more than a couple hours. We've tried to do the opposite of so many drug studies that tend to be, they want to cherry pick, you know, and just have the perfect Parkinson's patient without any problem. And I understand that they're looking for FDA approval. They don't want to have any problems. We're in a different boat. We're really trying to make this research real world application and take all comers, basically.
Okay, thank you. That's pretty much the end of the questions in the chat box. If anybody in our audience has a question, you can unmute yourself and ask it at this point. And I'm not hearing anything, so.
Well, good. Well, either I was clear or people are overwhelmed. They can reach out to us later if there's questions. Feel free to send an email to Scott Richards or myself if you have any questions about the research. And feel free, if you know people that might qualify too, we definitely want to spread the word.
All right, we would be glad to do that. I think I can.
One other thing I just want to mention is the research is completely free. I'm surprised that I have to say that, but I know sometimes people ask. I just want to be clear about any research that we offer. There's no cost to the patient. All of the treatments are completely free, and we'll help pay for parking and gas and things of that nature.
Excellent. So I speak on behalf of our entire group. We really appreciate you taking the time. I think this has been very informative, and hopefully you'll be able to recruit some.
Yeah, I hope so. And yeah, we'll spread the word. And any time, if there's other topics that you'd like to hear about, just pass the word through. And if there's probably somebody with expertise, even other than me around the university, we'll try to get that matched up. I know Dr. Falk is happy to talk in more detail about the research too, if anyone's so interested. I'll try to focus on the clinical stuff. But thank you so much for your attention. So I look forward to working with you guys again.
Okay, thank you very much.
Okay, bye-bye.
Bye-bye.